to our webinar this evening. My name is Juggy Gill, and I am the founder of Tenex Health. I'm joined this evening by Dr. Mihir Patel, and we're very gracious that Dr. Patel could make the time to provide this webinar. I think you all will certainly enjoy listening to his experience. He, like many of you, was an early adopter of Tenex about 3 years ago, and he'll share his initial skepticism with you, I'm sure, and then how he's evolved that skepticism into adopting the technology and then certainly using it for a variety of applications. So before we get into Dr. Patel's webinar, I wanted to just share some logistic issues. Everyone is on mute, and the purpose of that is so we can minimize any of the background noise so you can clearly hear Dr. Patel. After I make some introductory remarks about the technology and our clinical experience, that'll be very brief. I'm going to hand it over to Mihir, and he'll walk you through his presentation. At any time, what I would ask is the following. If you have questions as Dr. Patel is presenting, if you could type the questions in, you have the ability to do so if you're looking at the screen. And Mihir, are you able to show the screen up with everyone right now? I'm seeing the physician webinar. Perfect. On the edge of the screen, you'll see a box that if you click on the chat tab, there's an opportunity for you to type in your question. So I would invite you to do that. Underneath that box where you can type in your question, there's a tab that says where you want the questions to be posed. If you go and select organizers and panelists only, then those questions will come to Dr. Patel and myself. We'll be able to see those questions, and then at the end of the webinar, we'll be able to address those questions to Dr. Patel, and he'll certainly answer those. At the very end of the webinar, we will open up the mics, and so if anyone has a question that they'd like to pose directly and verbally to Dr. Patel, you're welcome to do so. We reserve the opening up the mics at the end. As you can imagine, it becomes very staticky and noisy. And just before I open up the mics, I would encourage everybody, if they can, if they're in a noisy spot, to please put their phone on mute, because if your background noise is there, then all the other attendees, the 30-plus attendees that are joining us, are going to be able to pick up the background noise. All right, so go to the chat section, type in your question, make sure the text questions are directed to the organizers and panelists only. You'll be able to select that yourself, and then we'll address your questions at the end. So with that, let me begin. I'm going to, introduce Dr. Patel. Dr. Patel is a board-certified orthopedic surgeon specializing in foot and ankle surgery. He trained at the Hospital of Special Surgery. He's got a tremendous focus in sports medicine, and he'll obviously tell you about his practice and then certainly share his experience with Tenex. What I'd like to do before we get into his experience is just to give a quick preamble on the product. I know many of you listening are relatively new to the technology, so let me kind of provide some foundation for it. So Mihir, I know you're controlling the slides. If you could just move to the next slide here on your side, then we can all see it. So one of the things we like to share with our customers is, where do we fit in terms of patient selection? I think many of you know when you think about chronic tendinoses, or in the case that Dr. Patel will talk about is plantar fasciosis, is the patient selection. And I think as a young company, we have hopefully gotten smarter of how to select those patients so they can achieve optimal outcomes. And those patients to us fit into this kind of bucket. I think everyone appreciates that Mother Nature can be very effective in treating this overuse injury syndrome, whether it's fasciosis or tendinosis. So conservative care is achievable and successful in many cases. Failing that, the other options historically have been either an open or arthroscopic approach. Here you can see on the bottom right screen an open approach for a plantar fascia release. And the objective there is to cut and remove that degenerated tissue. And the goal is to, as you do that, you're removing the pain generator and then promoting a remodeling cascade by the secondary or angiogenic effects. We believe in Tenex that we are kind of the best of both worlds. We're minimally invasive. We have the invasiveness of an injection, but our instrument, which is a needle, behaves like a scalpel. So it achieves the surgical goal, which is to cut and remove the tissue, but without going through healthy tissue and without the offending nature of a scalpel, we can do so with a needle. And one of the appealing features of this is that because it's minimally invasive, you can have a faster recovery time on the patient side. Next slide, please. So a little bit about our technology. We have an instrument. The instrument delivers ultrasonic energy, so that needle moves at the speed of sound. It moves in a longitudinal displacement back and forth, and that frequency, which is proprietary to us, has been determined to affect and specifically cut and remove necrotic tissue. That tissue is degenerated, as opposed to healthy tissue that has an elasticity of it. So you take advantage of the degenerated hard tissue, which is kind of surrounded by healthy tissue, which is elastic. That difference in density can be exploited through harmonic resonance, harmonic frequency. That's the movement of the needle, and that's what breaks down the degenerated tissue. And then that tissue is both aspirated up through the central lumen of that needle. Between the needle and the tissue is a sheath. That sheath protects the subcutaneous tissue. That sheath also allows delivery of fluid to keep the needle cool, and then both the tissue and the fluid is aspirated up. Next slide, please. The system that we have utilizes both a console as well as a disposable instrument. You should hopefully see that on your screen. The console has the smarts of the system, if you will, the dedicated frequency, a lot of the safety features. So all of that is preset into the console. The disposable aspect of this is single use. The cartridge is attached to the console. The instrument is literally a percutaneous approach, so after an 11 blade to give you a stab incision into the skin and a track to the necrotic tissue, that percutaneous needle is, again, delivered to that necrotic tissue where you effectuate the cutting and removal. I should say this is all done under image guidance. One of the attractive features of ultrasound, and I know Dr. Patel will speak about this, is you can identify the hypoechoic area. This still maintains itself as a clinical diagnosis, and I know Mihir will speak about this, that any of the imaging, whether it's MRI or in this case ultrasound guidance, that is confirmatory and definitive. But again, once the patient identifies this point tenderness and you see the hypoechoic area, that's kind of your guidance of the tissue that you need to target to cut and remove. Next slide, please. This is a snapshot of the patients we treated. In fact, we are probably eclipse 30,000. We're doing a number of patients per month. Again, this is a bit outdated, but suffice it to say, we've done at the minimum 30,000 procedures since the early part of 2012. You can see the distribution here of those 30,000 patients. The majority of those are in the foot and ankle, and I think it's consistent with the epidemiology and the incidence of Achilles tendinoses and plantar fasciosis. And but I provide this slide, even though we're talking about plantar fascia, just to give the attendees a snapshot of the other body parts that we've treated and had success with as well. Next slide. So one of the things, again, when Mihir was one of the first adopters of this, he didn't have the benefit of the clinical currency that we have now. He essentially, and he'll speak to it, took us for our word, and he certainly had some of our key opinion leaders that he spoke to. But as we've moved on, one of the things we're very proud of is the amount and the rigor of the clinical data we have. And I know the physicians out there listening, you can certainly get the summaries of all these papers from your local reps. But this, again, provides just the state of where we are. We have a number of prospective studies. They focus on, if I go down from top to bottom, elbows and knees and Achilles and plantar fascia. We also have some plantar fibroma experience that Dr. Patel will speak about. We also have some economic data that shows the benefit of Tenex versus an open procedure, and we've been able to actually calculate a cost savings for that. And net-net, what we see is that we sit around that kind of 85 to 90% success rate in terms of pain relief. It's a very safe procedure, as we've documented this. And then the other aspect of it is it appears to be a definitive procedure. As you think about tendinoses and fascioses, there's typically in the literature and even in community experience, there's a tachyphylactic response. There's a rebound in many of these patients. We were very focused on adjudicating whether that was the case with our technology, and we've tracked these patients up, well into 36 months, and we don't see that rebound effect. So it appears for the patients that it's been successful in treating, that effect maintains itself, and we've, again, measured this all the way out to 3 years. Next slide, please. I'm just going to give you a couple of snapshots of some of the studies we've done. This is on the Achilles. I'm going to have Dr. Patel talk about his experience himself. So this is a paper that was recently accepted in the Journal of the APMA. Dr. Ellis is a podiatric surgeon in Phoenix, and he looked at 26 patients with Achilles tendinosis. They had a symptomatic onset for over 18 months. Single treatment with Tenex. We don't advocate the use of any biologics. We don't advocate the use of any kind of additional adjunctive therapies. This is just a Tenex procedure in and of itself. We were able to measure the cutting time in this case. We measured the patient's outcomes both at 1 week all the way out to 16 months post-treatment. And what we found in this case was that about 88% of patients were pain-free at a month, and it was sustained out. And then a number of these patients, again, would have chosen to have the procedure done again. Next slide, please, Mihir. Dr. Rosden completed a study on plantar fasciosis, and I know Mihir is going to speak about his experience, but this was presented at the Society for Interventional Radiology. This paper, again, has been submitted. This looked at 100 patients that were symptomatic with plantar fasciitis, again, failed conservative treatment inclusive of orthotics and PT. Single treatment, 12-month follow-up. We didn't capture any complications in this patient cohort. And again, we looked at pain and the foot and ankle disability index for the lower extremities at 2 weeks, and then downwards on a sequential manner all the way out to 12 months. We saw improvement in the pain and the disability at 2 weeks. This was sustained at 12 months, and the total improvement was appreciated in 91% of the patients. Again, pain-free at 6 months and then 12 months. What I'll say is in this case, as well as some of the other bodies we've treated, there's not an immediate benefit. There seems to be a gradual benefit in pain relief. You can typically start to see this in about 2 to 3 months, and then it even continues on longer than that. But and I know Mihir will talk about his experience with the plantar fascia patients he's treated as well as and documented on. Next slide, please. I think that may be my last one, Mihir. Then I'll.
Yep, that's it.
Yeah, so I'll leave it there, and I'm going to put it in better hands with Dr. Patel to have him walk you through his experience. So Mihir, it's all yours.
Great. Thanks, Yogi. So all of us, for all the physicians out there, we've seen this plantar fasciitis over the years. Heel pain is in the orthopedic practice, in my practice, used to be a real nuisance, as all of you can imagine. Patients that come in with heel pain, you really didn't have a great solution to this kind of stuff. And our practice is a large practice here in Indiana, and so we'd see a lot of referrals with this type of stuff. And so, these patients that come in complaining about heel pain primarily. They had morning pain when they first get out of bed in the morning. It get a little bit better, then it gets worse across the day. And again, it's one of those things where it just continued and persisted despite doing whatever they thought might get better. And so just briefly on physical exam, when these patients had come in, if they hadn't had anything else done prior to seeing me, most of these patients would have pain with sort of palpation of the heel, very little swelling, no bruising, but they'd have point tenderness or sometimes some global tenderness across their heel. And a lot of these patients would end up having some gastroc tightness as well, and maybe some hamstring tightness as well that contributed to some of their symptoms. So, in orthopedic practice, we always get plain films, and on plain films, we would occasionally you'll see a spur. You may not see a spur on all of these patients. You may see some soft tissue swelling that may or may not be clinically significant. And with a lot of these patients, most of the patients that got referred to me over the years, they'd had the symptoms for more than 3 to 6 months, and so I always got an MRI if they didn't have an MRI from their primary care doctor or the referring physician, primarily to make sure that they didn't have a stress fracture. A lot of these patients would try and push through these types of symptoms, and what ends up happening is they end up getting a sort of a compensatory stress reaction at the insertion point of the plantar fascia on the calcaneus. And so, if you can see the cursor moving on the MRI, sometimes you'll see some edema in this in the inferior aspect of the calcaneus. So conservative treatment-wise, I sort of set, with patients that would come in, I always set the clock, I basically zero out the shot clock, and they're with me now. And so if they hadn't had anything done, or if they had had minimal stuff done, we always are very conservative in this town. We start with everything from the beginning, and then go from there. And so most of these patients, we would put them in the cam walking boot. If they came in with an MRI with a stress reaction across the calcaneus, if they didn't have a night splint, I'd put them in a night splint. With these patients, again, the night splint is sort of a catch-22. Most of these patients can't tolerate a night splint the entire night, and so we warn all our patients nowadays, if their toes start to go numb, and after a couple hours of wearing this thing at night, just take the thing off. But most importantly, put the night splint on before you get out of bed in the mornings, before you take that first step, basically to stretch out that plantar fascia and their gastroc while they keep their knee extended. And then if they progress with the night splint as the night goes on, they can definitely wear it through the night. They don't have to get up and take it off if their toes aren't going numb. And then the second thing we also counsel with the night splint is if they're sitting down, if they have any sort of computer tech job where they're sitting down more, if they're at a desk job, if they come home in the evenings, and if they're sitting around grading papers for the teachers out there, if they're watching TV, reading books, well, we tell them to put the night splint on while they're sitting around. I just don't want their ankle in a plantar flex position pretty much whenever they're sitting down. I want it stretched out. I want it at least neutral, if not higher, if they can tolerate it while they're awake. And that helped both preoperatively and then postoperatively with these patients. Now, in the refractory cases, we used to use casting. I've gone away from casting with a lot of patients. It's just a nuisance. If they happen to swell a little bit, then you got to bring them back in for the cast. And if it's their right foot, we live in Indianapolis, so I mean Uber just got here, and so you really can't take a taxi anywhere, as opposed to the coasts where the taxis are available. So if it's on their right ankle or on their right foot where they're having this problem, they can't drive with a cast on. And so I've sort of gone away from that. It used to be a decent treatment modality. And then a lot of the patients will show up with having had injections in that area that may have worked for a little while, may not have worked all that well. And I personally have gone away from any sort of cortisone in this area, partly because, and we'll get into this a little bit, when they have the cortisone shots, one of the side effects of cortisone is skin thinning, and down in anywhere in the foot and in the ankle, it's basically skin, bones, and tissue. And so with the cortisone, it tends to thin out the skin. So you really have to be careful if they've had a recent cortisone shot not to put an incision on there. You can run into wound complications from this type of thing. And so I'm very vigilant about when their last cortisone shot was, as far as doing any sort of procedure on them. And then the other, conservative treatment, you can put patients in heel cups. Then there's other procedures in the past that we've tried that really didn't work all that well. And some of the patients that we reported on did have some of those procedures, but again, they failed those procedures. And so again, we start from the beginning in terms of the conservative treatment, and then we go based on how the patient feels, and really how the patient feels. They kind of dictate pretty much whether we do this or not. And so historically, if one looks at this, if one fails all that conservative treatment, we had the open releases, and as you can see over here, this incision is a longitudinal incision, 3-4 centimeters in length. You put in these retractors here, and then you go and basically divide the plantar fascia, create pain relief from there. And what I would see was a lot of patients would end up having these open releases, yet this incision wasn't quite far enough down. Patients didn't get really the relief that they needed from the release, because they ended up with pain from the incision site. And so that was was one of the driving factors for me in terms of trying to find alternative surgical procedures to this type of thing in the ones that failed the conservative treatment. And in terms of conservative treatment, all of our patients, actually all of our patients have at least 12 months of conservative care between me and whoever is referring them into me before we undergo any sort of surgical procedure. And so then the next thing that came up were sort of the endoscopic releases, which I did fairly routinely prior to the sort of the Tenex thing that came out in 2011 or so. And this is the stereotypical sort of picture that you'd see through the scope. You see the plantar fascia there, and you go and divide the thing right there. And then the remainder of the plantar fascia, as you can see right here, was intact. And so you'd go address where the pathology was and where the patients were really point tender. And it was fairly effective. I had good results with this type of thing. But again, you had to take the patients to the OR. If you don't have necessarily a procedure room or a surgery center where the turnover times are better versus a hospital setting, this type of thing, again, would take you maybe 15 minutes, 20 minutes to do, and the turnover time's an hour. So in terms of efficiency, it was really inefficient to do these things from a practice standpoint. But it was effective clinically, which was, so we continue to do this for the patient primarily. And so I met Juggy back in 2011 when I was looking at alternative ways of potentially treating this refractory plantar fasciitis. And as a physician, we all have reps coming to us all the time, and Juggy's not a rep, he's a physician by training, that have the newest and greatest and latest thing out there that's going to solve all of our problems. And so I was skeptical, and I've always been skeptical up until I started seeing the results in the patients. And what ended up happening was we gave it a shot, had a couple of decent success stories, so I gave it more shots, and basically it became a very routine thing in my practice. And so, with the ultrasound, that's a whole nother caveat of sort of a learning curve in orthopedic surgeons, and I'm not quite sure how many physicians out there have a lot of experience with ultrasound, but it was something that I kind of had to learn myself a little bit as well. And once you get a feel for it, it's really, once you know the anatomy, once you figure out the ultrasound, it's really quite easy. And these are my sort of tips for those who've tried this. One of the things I learned really quickly was that you wanted to put lots of gel on the probe prior to placing that sterile sheath cover over it. A lot of gel is great. It allows you to visualize the plantar fascia well, it allows you to visualize the pathology well, and then the release. The nice thing about the ultrasound was that it allowed you to really evaluate the proximal and distal plantar fascia really well, as opposed to the scope where I couldn't really get distally unless I dissected all that well, which was nice to have. And then also medial to lateral, one could really be very precise with the ultrasound as far as measuring what the width was of the plantar fascia plus the thickness. Preoperatively, in the pre-op holding area, I'd always, or in the room, I'd basically identify the point of maximal tenderness of the pain, and so that's where we place the ultrasound at, and that's usually where the pathology is at. And then the other key with this is sort of keeping the ultrasound in line with the instrument. I wouldn't go 90 degrees, 90-90, what I call 90-90 in terms of 90 degrees to each other, because it's very difficult to see the tip, because again the tip is very small. And then obviously you keep your hand steady with the ultrasound, so whatever you're comfortable with is the key there with this type of thing. And so as far as the plantar fascia is concerned, and I'm sure all of you have seen Dr. Morey's paper on the lateral epicondylitis and tennis elbow that he had. And he talked about a lot of revascularization and that sort of thing after you do the Tenex procedure on the elbow. In the plantar fascia, it's a little bit different. The goal is basically to reduce the thickness of that plantar fascia. If you look at the MRI, and the radiologists see this really well, the thickness, they'll say there's a thickened plantar fascia, and usually it corresponds to the point of maximal tenderness for the patient. So the goal is to debride that thickened plantar fascia to help reduce sort of the inflammation in that area. And if the entire fascia is thickened in that area, what I've learned over the years is I'll just partially release that area. Again, it goes back to the endoscopic technique. You can release about 10% of that plantar fascia and really have no issues in terms of complications going forward in terms of creating a flat foot deformity or anything. I've never released an entire plantar fascia, in my career. But doing the partial release, you release that tension. Again, it comes down to the point of maximal tenderness for the patient. Release that area, and they get a great pain relief by doing that. And so preoperatively, what we're looking for, again, is history and physical that we talked about. I look for the gastroc tightness. You kind of look at heel valgus and varus as well, as far as basically telling the patients that after the procedure you may need a different type of orthotic or something like that, based on what their anatomy is. And then again, the MRI findings are a key with this type of thing. I've done this in combination with other procedures. Patients have come in with other issues, and in addition to the plantar fasciitis, they've had some ankle instability or midfoot DJD, and so we've gone and done with this sort of procedure with other procedures. And again, the key here is to make sure the patient has point-specific pain with this procedure, not global heel pain. And so with the MRI findings, if you see a stress reaction, I tend to treat the stress reaction until they don't have that global heel pain, and then I tell them basically we're waiting for it to get down to a specific point before we go and release that plantar fascia, or at least debride that area in their hind foot. So in terms of the technique, I've done all these supine. You can do them prone if you want. Either way is acceptable. Again, you prep and sterilize the area. I learned this from Dr. Mori. You want to create a wheel with that lidocaine, so you get maximal anesthesia right there, and then test the block out. And that comes back from my training. We did a lot of local stuff out on the East Coast. And you test the block with a pair of forceps just to make sure it's done, so you don't have to go start the procedure and then end up having the patient feel pain and then have to inject again and wait a couple more minutes before you do that. If they have medial sided tenderness, make the incision medial. That's what I've done, and then you place the ultrasound plantar in line with the probe. And so again, you put the probe over the point of maximal tenderness, and then I've done enough of these over the years where you utilize your tactile sense in the ultrasound, and you can watch that plantar fascia basically get debrided. And we've done some seminars at the academy, and actually at the foot and ankle meeting, and the physicians we went through with this really, once we sat down with them, they really understood how they could feel it, they could see it, and they could watch it get debrided all under ultrasound. And so again, in terms of the technique, partial release versus debridement depends on the patient, the MRI findings. You can measure the whole width of the plantar fascia with the ultrasound, and then with the ultrasound, I actually look for fat as a backfill as I debride the plantar fascia in that area. And the tip of the probe is really quite visible on the plantar fascia, so you know where that tip of the probe is. You're not passing point as you do it, and so you can see it. You can document it. You can take plenty of pictures along the way, send it to your PAC system, and then I utilize a medial approach if they're medial. In patients who have lateral symptoms, it's rare as far as my practice is concerned, but you can go lateral. I've done lateral, and the patients have done really well with that as well. But it's a rare bird to see lateral pain with plantar fascia, plantar fasciitis specifically, because most of these patients have some cavus in their midfoot. And the Achilles tends to pull medially there, and so and those patients with cavus, when they try to avoid the pain, they're going lateral, and they're overloading their lateral side to avoid the pain on the medial side. So in terms of the postoperative course, I put a stitch in the incision site. Again, I don't trust with these patients. As long as the stress reaction is healed, they're not globally tender and they're point tender, I'll put them in the KM walking boot. And I want them partial weight bearing on this, in the boot, and so I'll put a stitch in there. And again, that's my conservative nature of this. Just because if they're walking, I don't want that separating any. And their weight bearing is tolerated, with crutches, cane, walker, whatever they feel comfortable with, just based on their pain. But I have them continue their night splint and their boot, whatever they're comfortable with, at night specifically, to keep that thing at neutral position or up if they can tolerate it. And then I also continue with gastroc and hamstring stretching with all of these patients. And so our case series, I'm sure all of you have seen it. It was published in, and you know, this is our initial sort of results. We had 12 procedures, 7 males, 4 females, 4 revisions in these things. The average duration of symptoms, again, was at least a year, and it was just me. We did pre-op AFAS scores. They were sitting at 30.7, around 31. The average post-op score was 88.1. None of these patients recurred, and 10 of the 11 were follow-up as needed. I can report that all 11 are now follow-up as needed since we published this. And you know, the key with this is, you know, again, I was a skeptic of this procedure. It took me a while to get really put it out there, and now actually in our large group practice, which is very conservative practice when it comes down to it, many of my partners send me these patients since I've been doing this since, you know, the end of 2011 effectively, and then a lot of my partners, I'll do actually joint cases with them. So if they've got something going on and they've determined that the patient needs a partial plantar fascia release while they're there or whatever, I'll see the patient preoperatively just to make sure and confirm everything, look at their MRI with them, go over everything that we're going to go over with them, and then basically go there. And I go in there, do my thing, and then my partners go and do the rest of what they're going to do for the patient. And it's worked out well. It's great for me because my partners end up following all these patients, and I ask them in the locker room if they're doing well, and they said, well, we'll send them back to you if they're not doing well. And to date, nobody's really sent them any back, so I knock on some wood at this point. And so that, you know, that's the key with this, is finding point tenderness, and key it down to point tenderness, and then go after that pain. And if they failed all that conservative treatment, this has worked well. What we haven't really, and I'll probably write this up over the next couple of years, is sort of the patients that come in with bilateral pain, and that's another animal. With patients who come with bilateral heel pain, you know, one worse than the other, not so much equal. If it's equal, then I'm looking to make sure it's not their back or something systemic. But with bilateral pain, if it's one worse than the other, the patients usually get better anecdotally half the time on the other side because they've been overloading the other side. But in those patients that didn't get better, you know, after we've done all sort of the conservative stuff, we've gone back. They're sort of repeat patients, and they're like, you know, I'm tired of all this conservative stuff. Let's just go do this thing. It worked well on the other side. And so that in itself, between the patients and my partners and my conservative nature, the procedure works well. And I wouldn't be talking to you about it if it didn't at the end of the day. And so, you know, with this, these are the kids. We went to China just a little bit before we started this procedure, and you know, this is the Great Wall here, and so it's a bear in terms of heel pain coming into our clinics. It's a gradual process coming on. It's a gradual process going away, and you know, this procedure is basically a blend of the old with the new when it comes down to it. And having said that, you know, a lot of these patients, in terms of post-operative course, their heel pain will get better. Their point-specific tender pain will go away at 6 weeks. What a lot of the patients will complain about is just global, different type of pain in their ankle and their foot, usually at 6 weeks. And it's partly because they're walking now properly. And sort of like with the kids, I told them they have to walk up to we're going to hike up to the Great Wall, and we did. And with these patients, you got to tell them at 6 weeks, your preoperative pain is probably pretty much gone. You'll have a different type of pain that we're going to work through, and at that point, it's basically their body readjusting to the normal walking process. Thank you.
Mihir, that's a great presentation, as always. Thank you for your time. If you have the time, I've been getting a number of questions through the audience, so I'm just going to send them your way, and then
okay.
If you are able to kind of respond to them. So in no particular order here. So let me try to paraphrase the questions here, Mihir, for you. So number one, how do you choose a corticosteroid injection? How close to a corticosteroid injection would you perform a Tenex procedure, whether you've given the injection or somebody else from the outside? What's the delta for you?
Sure. So it's an average about 3 months. But what I wait for is I wait for that cortisone shot to wear off. And so when it wears off and their pain comes back, that's when you're fairly safe to go in there. So it's sort of patient specific, but generally speaking, it's at least 3 months.
So corticosteroid injection, wait 3 months for an effect, and then after that 3-month interval, then if they're still symptomatic, you'll consider them for Tenex.
Yes.
Yeah. Okay. Perfect. Thank you. A technical question that came through: when you're performing the procedure, how deep do you place the 11 blade, and what's your kind of sense of difficulty with getting the 11 blade with the plantar fascia thickness that's resident there?
Yeah. So the 11 blade is just a superficial cut, and then what I have is then you just sort of bluntly dissect. And just to the point of the plantar fascia, and then what I'll do is I'll define the plantar fascia both superiorly and inferiorly with my probe, just to make sure that we've got the width of it. And again, it's tactile plus the ultrasound, and between the probe and the ultrasound, I'll figure out the thickness of the plantar fascia, and you've basically got it at that point. And so the 11 blade is specifically only just for the superficial skin incision.
Perfect. Good. Another kind of related question to technique here: when you're putting the Tenex instrument in and you're trying to treat your focal lesion for plantar fasciosis, for example, and you need to redirect it because there's a wide area of tendinosis, how do you go about, how hard is it to go about redirecting the instrument while it's in the body habit?
Sure, and that's a good question. So with this, what we end up doing is I basically attack the center of the lesion first, and then I work my way distally and proximally by pulling back on the probe and then going at that site. It's not a windshield wiper sort of technique. It's more of a hammer technique where I pull it back, push it in, pull it back, push it in, both, and then go distally and then proximally.
Thank you for that. I'll just kind of emphasize that, the instrument is not designed to absorb side load pressures. So Mihir is talking about a windshield wiper sideways. It's not designed to do that. It's intended is to kind of go back and forth. You move the instrument back and forth. You will need to redirect it based on the size of the lesion. And I always describe that the instrument is kind of like a jackhammer or a Pac-Man, that at its tip it's chewing up the tissue and then removing it. So if you keep that kind of mechanism of action in mind, that might help your technique. The other question here that's coming through, this is more from an economic questions. When you are framing the language for reimbursement, what pitfalls have you come across with language and insurance coverage, language for either your op notes dictation or for any kind of pre-authorization?
Sure, and I've used it since 2011. We've used basically division of plantar fascia for this. That code 28250, the code exists, and so it's not. It's worked well over the years. Our billing company, we use in full disclosure, we use an outside billing company. It's not our own billers, and so they double check and triple check everything, and we've never had an issue with that particular code.
One thing just to add to that, for any of the physicians in the room, or excuse me, in the audience, if they have questions about the actual op notes, suggested op notes, feel free to reach out to your local reps. We've, as a company, provided them with dictation templates, samples, and I would just underscore Mihir's point. If you use those, I think it's a legitimate cutting of fascia and soft tissue. That's what our FDA clearance was, and I think Mihir certainly emphasizes that point. A couple other questions, Mihir. When you're looking at patients to evaluate, and from your experience of treating these patients, looking back, who would you have not treated in terms of patient selection? What's the profile of patients that you would not consider treating?
I do not treat diabetic patients. with a lot of surgery ever. Part of it is that if one looks at all the orthopedic literature, a lot of those patients may get plantar fasciitis because they have gastroc tightness, and so based on the literature out of Washington University and Dr. Johnson, Jeff Johnson, that needs to be treated as well. And so I haven't never done any diabetic patients, and all my smokers I don't do until they quit smoking. Those are the ones. Those two are the main ones. And then if they've got vascular issues, if they're a vasculopath, but most of those patients don't really show up in our offices. These are active patients primarily. They're more sports-related types of patients.
I don't think you have any diabetics or smokers in Indiana. Do you, Mahir?
Yes.
Yeah. All right. Another quick technical question here for you, if I could. When you're doing the procedure, are you doing this longitudinal to the plantar fascia, the plantar fascia fibers longitudinal, or transverse? Or
transverse.
Other?
Yeah, transverse. Yeah. And so one goes longitudinal by pulling back on the probe and then going distal and proximal. That's how I treat the longitudinal nature of the plantar fasciitis.
Great. Another technical question: have you debrided between the fascia and the calcaneus?
No, I have not. Partly because most of all the patients I've ever seen were always tendered more distally. I mean, they're not right at the insertion point, and so all I've ever had to do is basically it's a tension band effect. So if you release the plantar fascia where it's partially release it where it's maximally tender, you take the tension off of it and the pain goes away.
Great, thank you. Another kind of insurance question: if you're using the code that you suggested to all of us, do you also bill for ultrasound guidance for the percutaneous tenotomy?
I think you can. I don't, because our ultrasound machine isn't. Yeah, you have to document. I think you have to document the and save the ultrasound images, and we don't have the capacity to save those ultrasound images to our PAC system, and so I just do the 28250 code, and that pays me enough and pays the facility enough and everything else to cover all the costs of this of the device itself. And then I give the patient the ultrasound pictures, and so they have them.
Perfect. Great. The other question here is: what do you expect to see during Tenex when treating your plantar fibromas? I know you've had some experience. You've actually also just published on that. So very quickly, and I want to be sensitive to your time and everyone's time, what's been your experience with plantar fibromatosis?
Yeah, so specifically painful plantar fibromatosis is what we've treated with this. And if it's painless, I don't go and treat it. We just put in different orthotics and that kind of thing. You treat it conservatively. But with the painful ones, basically I go into the center of the lesion with the ultrasound and debride it out. And in our practice, we actually have an orthopedic tumor guy, and so he's taught me well. So a lot of the times I'll send the shavings and stuff to pathology just to make sure it isn't something else. It isn't some funny presentation of melanoma or something like that one can get on the plantar aspect of the foot. And I make that incision longitudinal just in case it ends up being something bad, some sort of sarcoma or anything. But they all get MRIs preoperatively, and then we go in and just basically go in the center of the lesion and debride it out.
I'm assuming you're doing this by image guidance, ultrasound guidance.
Yeah, with the ultrasound.
And so what tips can you provide or guidance of what you're seeing on ultrasound? What changes are you seeing from an echogenesis standpoint?
Yeah, that's a great question. And so what happens is, this is a little bit different than plantar fasciitis, because usually these plantar fibromas are in the non-fatty part of the foot. And so what ends up happening is that area will just fill up with the fluid from the device. And so as that tissue goes away, you'll get a sort of a hypoechoic area on the ultrasound where it's filling up with the fluid.
Yeah, so it becomes either hypoechoic or anechoic, because fluid would present that way. Yeah.
Right.
Yeah. Okay. Great. Mihir, one more question here for you, and I think we'll let you off the hot seat. Have you followed up a Tenex procedure either during the procedure or staged afterwards with the use of any biologic injections?
I haven't, but that would be my fallback if this didn't work. Over the years, this has worked, so I've never really had to institute anything else beyond this when it came down to it.
Perfect. Very good. Well, I've got about 15 past the hour, so I'm just going to forewarn everybody. I'm going to ask our organizer here, Toby, if he can start unmuting the phone, so if folks want to ask Dr. Patel questions directly. So, Toby, if you can start doing that, it'll take a few minutes. As he's doing that, if you could please put your phone on mute if you're in a noisy spot, and then certainly unmute it. And then certainly unmute it as you ask the questions. As Toby's doing that, if you are in a phone area that has a lot of noise, he will have the privilege of muting you back on because that's a bit interference with everyone else. So if you just give us a few minutes to go through that, and then we'll open up any questions, if you have any, to Dr. Patel.
Hey, Juggy, I think I see another one. Collect the tissue for pathology for the plantar fibroma.
Oh, yes.
You can. So I send that to pathology. That bag has everything in it, and so we just send everything. We send the bag to him in the specimen cup.
So, Toby, you just give me a heads up when everyone is sufficiently unmuted. Okay. I think Toby's been very kind and gracious to unmute everybody. So if anyone has any specific questions for Dr. Patel that you'd like to post to him, I think all the mics should be live right now. So just to finish, I had one question for you here myself as I was listening to you. When you tell the patients, because one of the things is I think obviously setting expectations. So what is your script for your patients that come in with stereotypical medial plantar fascia pain? What do you tell them about what they should experience during the procedure? And what do you tell them, Mihir, about what their outcomes in terms of resolution of symptoms should be and what the extent of the resolution of symptoms? What's your script?
And with all these patients, I tell them it's 3 to 6 months. And so most of the patients are better at pretty much all of their pain's gone at 3 months. And so what we see is at 6 weeks, their preoperative pain's gone. They usually have some global heel pain and midfoot pain. Some of these patients may have a lot of these patients have some arthritis across their midfoot that starts to bother them. And actually that's a great sign because what happens is if the brain's perceiving other pains besides what they had preoperatively, it's a good thing for the preoperative pain because that means that's probably gone or close to being gone. And so that's usually at 6 weeks are really quite well with the preoperative pain. And then at 3 months, they're usually feeling really quite well, just overall. In the study that we published, the 10 of the 11 patients that did well with it at 3 months were great. The one that wasn't was actually a patient that had bilateral symptoms, and so we ended up doing the other side at that point, and he resolved his pain on that side at 3 months after that. So at 6 months, he was in excellent shape, and he had been on disability with this for about 18 months, and he went back to work, which was a great success story for society.
Okay. Thank you. One more question here that's come through here, the panel. Excuse me, from the audience here. Going back to fibromas, when treating fibromas, do you feel a reduction in the size of the lesion immediately?
Yes, absolutely. And so what will happen is you'll be taken out, and you can palpate that lesion as you're going, and so it'll become, where it was preoperatively it's a hard nodule that you can palpate. As soon as you get done taking it all out, it's no longer, it's very soft, and it's actually very blotable with the fluid that's in there. And then usually we'll just push some of that fluid out of that area, and it becomes a very soft area, and you've done enough at that point.
Again, another final question here on the fibromas. Do you treat the larger ones that are more calcific in nature?
Yeah, and that's the nice thing about the machine. Like the machine, you can put on that higher speed, and it can debride out the bone too. I've never used that the probe for large osteophytes, but with the calcific fibromas, where it's focal tenderness in that little area, you can switch it on the console, and that'll take out the bone in a really nice fashion.
All right, very good. Well, Mihir, we've almost taken up an hour of your time, and I want to thank you for that. As always, an exceptional presentation. Content was rich and well described as well, as always. For the audience members, this webinar will be recorded. It is being recorded, and if you give us a little bit of time, we'll have it uploaded onto our website, and then you can certainly go back and get additional understanding from it. So with that, Mihir, thank you for all your time, and for all those attendees that spent their evening, thank you again for taking the time, and I wish everybody a very nice evening. So thank you again.